Welcome everyone to a deep dive into analgesic nephropathy, a serious kidney disease often overlooked. In this video, we'll explore its causes, how it affects the kidneys, its prevalence, how it manifests, how it's diagnosed, treated, and importantly, how it can be prevented. We'll also touch on recent advancements in understanding and managing this condition. Let's begin. Analgesic nephropathy, as the name suggests, is primarily caused by the chronic, excessive use of pain relievers, specifically combinations containing two or more analgesics. Historically, combinations containing phenacetin were the biggest culprit, but these have been largely phased out due to their toxicity. However, combinations containing aspirin, acetaminophen, also known as paracetamol, and caffeine or even single-agent overuse of NSAIDs like ibuprofen or naproxen can still lead to this condition, especially with long-term, high-dose use. It's important to remember that this is an occasional use. It's habitual and often driven by chronic pain or even psychological dependence. The damage caused by analgesics to the kidneys is multifaceted. The primary mechanism involves damage to the renal papillae, the innermost part of the kidney. Analgesics, particularly phenacetin metabolites and NSAIDs, are concentrated in the medulla of the kidney. This leads to vasoconstriction of the blood vessels supplying the papillae, causing ischemia or lack of blood flow. Over time, this ischemia leads to papillary necrosis, the death of the papillae tissue. This necrosis disrupts the kidney's ability to concentrate urine, leading to other problems. Chronic inflammation also plays a significant role, contributing to scarring and further damage to the kidney tissue. This progressive damage impairs the kidney's ability to filter waste products from the blood, eventually leading to chronic kidney disease. Analgesic nephropathy is difficult to pinpoint epidemiologically because it often goes undiagnosed until significant kidney damage has occurred. Historically, it was more prevalent in countries where phenacetin containing analgesics were readily available. However, even with the reduction in phenacetin use, the condition persists due to the widespread availability and over-the-counter access to other analgesic combinations and NSAIDs. It tends to affect women more often than men, and is more common in individuals with chronic pain conditions, such as headaches or musculoskeletal pain, and those with a history of substance abuse or psychological distress. Understanding the risk factors is crucial for early identification. The signs and symptoms of analgesic nephropathy can be subtle initially, often mimicking other kidney diseases. Early symptoms might include polyuria, frequent urination, especially at night, and nocturia, which is waking up at night to urinate. As the condition progresses, individuals may experience fatigue, anemia, and symptoms associated with chronic kidney disease, such as swelling in the legs and ankles, high blood pressure, and electrolyte imbalances. Because the kidneys are unable to concentrate urine effectively, dehydration is a common problem. In advanced stages, symptoms of kidney failure, such as nausea, vomiting, loss of appetite, and mental confusion, may develop. Diagnosing analgesic nephropathy can be challenging because its symptoms overlap with other kidney conditions. A thorough medical history, including a detailed account of analgesic use, is crucial. Urine analysis can reveal abnormalities such as proteinuria, protein in the urine, and hematuria, blood in the urine. Imaging studies, such as ultrasound, CT scans, or intravenous pyelograms, can help visualize the kidneys and identify papillary necrosis. A kidney biopsy, while invasive, may be necessary to confirm the diagnosis and rule out other causes of kidney disease. Ultimately, a combination of clinical assessment, imaging, and laboratory tests is needed to arrive at an accurate diagnosis. While there aren't distinct types or formal classifications of analgesic nephropathy, it's often categorized based on the severity of kidney damage. Stages of chronic kidney disease are used, ranging from stage 1 with minimal kidney damage to stage 5, which represents end-stage renal disease and requires dialysis or kidney transplantation. The stage at which the condition is diagnosed significantly impacts treatment options and prognosis. The cornerstone of treatment for analgesic nephropathy is immediate and complete cessation of analgesic use. This is crucial to prevent further kidney damage. Supportive care focuses on managing the symptoms of chronic kidney disease, such as controlling blood pressure, treating anemia, and managing fluid and electrolyte imbalances. Dietary modifications, including restricting protein and sodium intake, may be necessary. In advanced stages, dialysis or kidney transplantation may be required to sustain life. Managing underlying pain conditions with non-analgesic approaches, such as physical therapy, acupuncture, or cognitive behavioral therapy, is also essential to prevent relapse. Prevention is paramount when it comes to analgesic nephropathy. Educating the public about the risks associated with chronic analgesic use is crucial. Encouraging individuals to seek medical advice for chronic pain management, rather than self-medicating with over the counter-medications, is essential. Healthcare providers should be vigilant in monitoring analgesic use, especially in patients with chronic pain or those with a history of substance abuse. Promoting alternative pain management strategies and limiting access to combination analgesics can also play a significant role in preventing this condition. The prognosis for analgesic nephropathy depends on the extent of kidney damage at the time of diagnosis and the patient's adherence to treatment recommendations, particularly cessation of analgesic use. Early diagnosis and intervention can significantly improve outcomes and slow the progression of kidney disease. However, if the condition progresses to end-stage renal disease, dialysis or kidney transplantation may be necessary. Recent research is focusing on identifying biomarkers that can detect early kidney damage from analgesic use, as well as developing strategies to prevent analgesic-induced vasoconstriction and inflammation in the kidneys. Future research may also explore the potential of targeted therapies to protect the kidneys from the toxic effects of analgesics.